Okay, here we go. All right, this is the story of the appendicular skeleton. Now remember, the appendices are your arms and legs, okay? But it also includes your shoulder girdle, which consists of your clavicle and your scapula. And it also consists of your pelvic girdle, which consists of your pelvic bones, not to include the sacrum. Remember, the sacrum is axial, even though it makes up part of the ring that you think of as the pelvis. I don't want you to learn numbers. You don't have to know there's 126 bones in this. There's a couple of numbers you'll have to know, but I'll point those out to you. So remember that the appendicular skeleton includes all all the bones of the arms and legs, and the shoulder girdles, the supportive girdles. There's the pelvic girdle down here, like I said, and the shoulder girdle up in your arm. In your shoulder. There we go. So here's numbers. Once again, I don't care that you know those. I will tell you that you're going to need to know that there's 14 phalanges in the hands, and there's 14 in the feet, which means there's 28 on both sides, according to this list here. That's about the only thing I can think of that you need to know numbers of. And please notice that the axial skeleton coming down the middle here includes the vertebrae, the rib cage, the sternum in front, the hyoid bone, which is floating up in there, and the sacrum down here. But the appendicular skeleton, the one we're talking about today, involves everything else. Okay? Including the leg. Okay, so let's start by talking about the shoulder girdle, which is what connects your arms to your body. And I always find that this is something that most people have probably never thought about. Because, you've always heard that arm bone is connected to the shoulder bone and the shoulder bone is connected to the whatever. But the point I would make is the way that those connections actually occur is like this. There's this collarbone called the clavicle, right? And it goes right here. This is the only point right here, actually it's on this end, that's the only point where your arm connects to your body. It's right there, at the manubrioclavicular joint, right here, right, which is right there. Then the clavicle goes out here to your shoulder blade, which fits right here, like that. And the clavicle actually attaches out here. It's kind of a loose connection, it would seem like. This is what happens when you get a shoulder separation. These get ripped apart. And that's a shoulder separation. We'll get to that in a few minutes. Then you've got your scapula, which is a very weird bone. And once again, this part of it lays on your back here, and you think it must attach to your ribs, but it does not. There's lots of muscles between this bone and your rib cage, so there is no bone-to-bone connection anywhere back there. And then this joint right here, which is called the glenoid joint, attaches to the head of your arm bone called your humerus, and that fits into that little socket right there. Okay, so that's just the basic way that these things are connected. Let's go back and go through that. I must have been sitting on the button here. so this is the pectoral girdle or the shoulder girdle. It holds your shoulders up, provides a base for your arm movement, and consists of simply 2 clavicles and 2 scapulae. And this is the only place where the axial skeleton is connected to the arm. Clavicles are called collarbones. They look like this. You should know what they look like. You should be able to tell whether this is a right one or a left one. You should be able to tell whether this is the front or the back. You'll get to figure that out in lab. There's 2 ends to it. The manubrial end, which is where it intersects with the manubrium, part of the sternum, right? And it also articulates on the outside with the scapula, which I just mentioned. So here it is. Here's the things to know about it. You need to know that the really flat end over here is the sternal end. So when you look at the bone, this is the flat end. This is the one that attaches right here. I think this is the right one. Goes right there. Okay, so this flat end attaches medially, as illustrated over there. And the acromial end is this kind of more rounded, flattened kind of area that is going to attach to the acromion. The acromion is this bulge right here on the scapula. And remember, the acromion was the point of your shoulder. We learned on day 1 of 231. Okay. Notice that the clavicle is basically flat in one direction, and it's flat. It lays front to back like this. It's flat this way. Okay. Notice that there's a big bump on it over here, which is called the conoid tubercle, right here, with muscles that are going to attach to that you'll learn next chapter when we get to muscles. I think that's pretty much it. So here's the jugular notch, remember, of the manubrium, which is part of the sternum, body of the sternum, xiphoid of the sternum. Anyway, clavicle. Let's talk about the scapula. The scapula is really an interesting bone. You can't get it confused with any other bone in the body. Nothing else looks anything close to this. The scapula, you have to remember that this is the main joint. This is the shoulder joint right here. And so it's always going to go on the lateral side, on the outside, right? Because that's where your arm is attached to it. The flat side goes against your chest. The other side sticks out the back. Now, you can feel these things yourself. Here's your acromion, and if you just reach up here, you'll feel it. That's where the clavicle, here, follow your clavicle out to it. Clavicle comes out to the acromion, okay? And then there's this spine down the back of the clavicle, the back of the scapula here, that you can also feel if you just push around farther back on your back, because remember, this thing is going to lay like this, so you can feel it and know what you're dealing with. The glenoids you can't feel because you see it's completely covered with a bunch of ligaments and stuff, and of course the humerus is going to fit in there like that. So you really can't feel the glenoid because it's deep down in there. Okay, the anterior. Let's talk about the scapula itself for a minute. It's a big triangle. I think you can see that. It articulates with both the arm and the collarbone. The anterior surface is called the subscapular fossa. So this is the subscapular fossa. If you think about this laying on your back, it's below, coming from the back side. It's really the anterior surface, but it's called the subscapular fossa, below the scapula. It has 3 sides. This is really silly, but superior side, medial side, lateral side. The lateral side is also, since it's the one that lines up closest with the armpit, it's also called the axial border, axillary border. Whoops. Axillary border right there. And then the medial border, mid part, is pretty much lines right up with the vertebrae. They're going down the middle, because remember, this thing is going to fit on your back like that. So this is also called the vertebral border. 3 corners, superior angle, inferior angle, and lateral angle. I just don't think I'll be asking you those things, but they make so much sense, it's easy not to at least mention them. The scapular head is really this thing here, which contains the glenoid cavity. The glenoid cavity is what articulates with the humerus, which is your arm bone, and it forms the shoulder joint. So the main shoulder joint is right in there. And I think I've mentioned to you before, but the shoulder joint has the largest range of motion of any joint in your body. And, you know, you can see how much you can deflect your shoulder. The other thing is the coracoid process. This is the coracoid process right here. It says extra bump. Remember, the big one's the acromion, little one's the coracoid. It's more in front, so it's kind of, you dig down in here, you can usually feel it, but it's kind of behind the collarbone as well. The coracoid is going to have a bunch of muscles attached to it that make you do things like this, your pec flies and your, you know, all your bodybuilders here. The acromion is the big one here. The acromioclavicular joint is the one I mentioned already. It's where the clavicle hooks up with the acromion here, and that's called the AC joint. You've heard it referred to on television with guys getting injured. They say, oh, he has a separation of his shoulder. That's one name for it. Or he has torn his AC joint. And that means that the ligaments, because that's really all that holds these two things together, have been torn apart. A lot of times a football player, if he's reaching out to tackle somebody and gets hit like this, he'll tear his AC joint. The way you do that, for those of you going into x-ray, the way you x-ray for that is you have somebody hold a weight, or hold weights in both of their arms, in both of their hands rather, and like this, and then take an x-ray from the front, and it will bring out the fact that this has been ripped loose. It's separated. There's different degrees as to how far it's pulled apart, but that's an AC tear or a shoulder separation. Okay? There's all the fancy stuff. I think I've talked about all of it before. A couple of things that I didn't mention. This is the front side here against the ribs. This whole thing's called the body of the scapula. Okay. This thing across the back is called the spine of the scapula. And on the back side here, there are two fosses, two big flat areas where a whole bunch of muscles are going to attach. These here, this one is called the infraspinous fossa. Get it? Infraspinous, below the spine. This is the infraspinous fossa. And this one up here is called the supraspinous fossa, just above it. And I'll just tell you right now that you're going to find that there's a big muscle attached here that's called the infraspinatus. And there's a big muscle that's attached up there that's called the supraspinatus, okay? So all this stuff sort of starts fitting together as we get farther into it, but just keep that in mind right now. Infraspinous fossa, supraspinous fossa, spine in between. There's a neck to it, whatever, that's not worth much. And remember, the undersurface, the flat surface, is called the subscapular fossa on the front side. The whole thing is one big flat subscapular fossa. I've mentioned these things before. I won't say them again. The upper limbs, now we're going to talk about the upper limbs. The upper limbs consists of the arms. Remember, this is the arm up here. But remember, this is not the leg right here. The leg is down there. So the arm and the forearm, okay, the arm has one bone, which is called the humerus, looks like this, and the forearm has two bones in it, the ulna and the radius. And I should probably start pulling them out like this. Okay, ulna and radius. I'll bring them up in a few minutes. Okay. This is wrong. It does not articulate with the pelvic girdle. It articulates with the pectoral girdle, pectoral shoulder. Pelvis would be down here. I don't think your arm bone articulates down there. Thank the book company for that The humerus is very interesting, and you need to know the parts of it. You need to know the names of all these bulges that are on it, because they're actually pretty critical as we start talking about how the bones articulate, how they hook together. So let's kind of start through that and say that the humerus has two big tubercles on it. Approximately, it has a greater tubercle, which is this bulge right here, and it has a lesser tubercle right there. And between the two of them, there is an intertubercular groove. See, the little groove comes down there between it. The head of the humerus is nice, round, flat, articulating surface. This is a ball and socket joint. The thing you have to remember is it's just not a very deep socket. See, the glenoid is it's just not very deep at all. As opposed to when we get to the hip, you'll see that the hip socket fits all the way up in there pretty well. But you can't move your hip near as much as you can your shoulder. That's where the joint capsule is, obviously up here on top. The anatomical neck is the one that ends right here at the edge of the joint capsule, and then there's the surgical neck, which is where the metaphysis is, and it's right about here, down a little further. Those become important because little old ladies break their arm in those two spots, one of those two spots. Usually, if they fall on their arm, not that younger people can't break their bone. I throw myself in the younger category there, which is probably wrong. But anyway. Down the shaft of the humerus is a bulge here called the deltoid tuberosity. And guess what attaches there? The deltoid muscle. The deltoid muscle is this big muscle that makes your shoulders look sexy, I guess. And people work really hard on their deltoid muscles, lifting weights. And to lift, if you've got weights in your hands, if you lift them this way, you're working on the middle part of your deltoid. If you lean over forward and do them like this, you're working the posterior part of your deltoid. And if you lay on your back and you're doing them like this, you're working on the anterior part of your deltoid. So we'll get to the muscles more next chapter, but so you know. There's a little groove out here, down here lower, which is, I think, this one right here, which is called the radial groove, where the radial nerve is going to run through. And this is this right along here. Radial nerve is one of the three main nerves that go to your hand. We'll be learning those two. The distal epiphysis is the distal end of the humerus, and it has a number of things you need to know the name of. The first thing it has is the medial and lateral epicondyles. And if you'll all just take your arm and lay it out here and squeeze your elbow, the two bony prominences on the medial side is called the medial epicondyle, and the one on the lateral side out there is called the lateral epicondyle. Now remember, anatomic position to keep those straight. Because obviously, if you flip them over, just the opposite. Okay, the condyle of the humerus is this articulation point right here. This whole smooth part on the bottom of the distal end of the humerus is called the condyle, and it really has two parts. I shouldn't get ahead of myself here, so I won't. This part is called the trochlea. Trochlea means pulley, or it means a joint that has a groove in it. So this is the trochlea right here, the two parts right here that form the joint that's going to work with your ulna right there. And then there's the trochlea has two fosses associated with it. One is back in back. One back here in back is called the olecranon fossa. And watch what happens here. This is the olecranon. This is the thing when you put your elbows on the table, you're putting your elbow on the olecranon, this thing right here. So the olecranon, this thing fits in here like this, And when you extend your arm all the way out, like that, then this goes up into there, and that's so that the olecranon can fit into the olecranon fossa so that you can actually open your arm till it's straight. On the other side, on the front side, there's a thing called the coronoid fossa, and when you bend your elbow, the coronoid, this is called the coronoid right here, and it's going to go into the coronoid fossa right there so that you can bend your arm all the way up, okay? And you need to just take the bones in your hands and figure that out. So this is the coronoid, this is the coronoid fossa. That's important when we have our arm flexed. This is the olecranon, this is the olecranon fossa on the back so that we can straighten our arm all the way out. Make sense? The other hump down here on this thing is over here to this side. So here's the trochlea right here that the ulna is going to articulate with. But over here is this thing called the capitulum. Capitulum. And this is the other bone called the radius, okay? And the radius is kind of cool because you notice it has a nice little smooth divoted thing down on that end, and that thing is going to fit right on the capitulum, okay? So the head of the radius, socket at the head of the radius, fits right on the capitulum, okay? Now, I think I've already showed you guys over in lab how cool these things kind of work together. Try to put them together like this. It's hard for me to hold all this together up here. But I got that on the wrong side. And it's maybe because these don't match. One's right and one's left. That's a problem. You got to figure that out. And I didn't take time to sort through this. But anyway, so the capitulum here, this round ball, a capital building, the way I think of it, it's nice and round. That's where the head of the radius is going to fit right in there. And remember that the radius does this. You see, so the radius really all it does is kind of twist. And it twists right up against that thing right there. Here's pictures of all these things that we just talked about. There's the capitulum over there. This is the trochlea down here. Now, let me just tell you, when you're studying this stuff, the first thing you do when you look at a diagram like this one right here is you look and figure out which side are we taking pictures of, okay? So this is the right humerus. That's the front of the humerus, the front of the right humerus. Now remember, this one here, the one I have the picture of here is a left, you see? So it's going to screw you up if you don't pay attention to which one's right and which one's left. I mentioned all those things. The forearm, also called the antebrachium. I don't know how that doesn't seem like a very important word to me. The antebrachium, you'll see it in the book, consists of these two long bones, the ulna and the radius. Well, let me give you a couple hints about the ulna and the radius because I thought this was rather earth-shattering when it first dawned on me. The ulna is really big at this end, you see, and it's really pretty little at this end. The radius, on the other hand, is pretty little up here at the top, where it's going to fit like this, and yet it's pretty big down at the bottom end. The radius bone is the main bone that's going to make up your wrist down at the far end. So ulna, big at the top, has this big hook on it, and the radius, all it has is this little socket at the top, and it's pretty big down at the other end. Yeah?
So like one way you can think of it is the big end of the radius articulates with your big thumb.
There you go.
And the end of the ulna is smaller, but articulates with your smallest finger.
There you go. Right. And, you know, we'll learn a lot of things called radius and ulna. The The radial nerve supplies this side of your hand. The radial artery is the one you can feel your pulse in right here. Okay, the ulnar artery is over here on the other side. It's kind of deep, so it's harder to feel, but it's down there, and so forth. So yeah, this is the radial side of your wrist. This is the ulnar side of your wrist. And however you can figure out to memorize those or to remember them and keep them straight forever, it's a good thing. The olecranon, let's talk about the ulna here for a minute. I've already kind of touched on it, but the olecranon is the big thing at the end of it that you put your elbow on. It's the point of the elbow. It is the olecranon forms the superior lip of the trochlear notch. This whole thing here, this notch here, is called the trochlear notch. And the trochlear notch is actually formed of the olecranon on this end of it and the coronoid on this side of it. Okay, remember I talked about the bosses that those things fit into that are on this. So the coronoid process is the inferior lip of the trochlear notch here. The ulna articulates with the humerus. As I said before, when the arm is extended, the olecranon fits back into the thing on the back called the olecranon fossa. When the arm is flexed, the coronoid right here goes into the coronoid fossa, which is on the front of the humerus here. Okay? A couple of other articulations that you need to be aware of are the radial notch. The radial notch is right here. It's right up at the proximal end of the ulna. There's a very clean notch there, and that is where the radius is going to fit in and articulate with the side of the olecranon. And once again, I think I have the right and the left one here, but I don't have any others with me. Okay, not a problem. Just know that this is the radial notch where the radius is going to fit into the side of the ulna. Ulnar head, prominent styloid process attaches to the articular disc. Ulnar head. Where's the ulnar head? That's down at this end, where there's a little smooth spot down at the far end of the ulna. And also there's a little styloid process down here. This little styloid process forms part of the wrist joint. And believe me, when these things line up, they kind of line up like this. So that there's a styloid process on this side and there's a styloid process on the other side. And that keeps your wrist bones from going too far off to the side. We move our wrists this way, but we don't want our wrists slipping off the side. Make sense? Here you go. Look down here at this end. You notice there's a styloid process of the ulna, which is obviously on the medial side, and the styloid process of the radius over here, which is on the lateral side.
What's the thing that you can feel?
Thing you can feel on the back side
Yeah,
here.
that bump right
Okay, what would that be? That's your ulna, yeah. It would be the ulnar head here. Notice that the radius up here fits into that radial groove. You don't really see it in this view, but right up there. And there is a joint there between the ulna here and the radius there, which is called the proximal. I can't read that word. Radio-ulnar joint. Wow, this looks like dots up here close. It's not very clear, is it? I think we need to upgrade our cameras. I mean our projectors. Anyway. Okay. Between the two bones running all down through here is an interosseous membrane. It's a really tough membrane, and it holds these bones about the same distance apart all the time. So whether they're bent or whether they're rotating around on each other, the interosseous membrane holds them together about the same distance through there. Very tough. It does not expand. I think I've said enough there. The radius is the lateral bone of the forearm, as shown here. It has that disc-shaped radial head just above the neck. This is called the neck of the radius right here. And the radial tuberosity is just below that. It's right here. And you probably wonder, well, why is there that bulge there on the radius? Well, that bulge is going to fit right there. And what do you think might be attached to it? Huh? Biceps, exactly. So, I'll show you my pitiful little biceps here. My bicep. You follow you can all do this, by the way. You feel your biceps up here, and you follow it down. It turns into a tendon, and that tendon attaches right there. And the thing that it inserts in is not on this side of the joint, it's on that side of the joint, right? Because when it contracts, it's going to pull from this tubercle right here. It's going to pull this up. It's going to cause your arm to go up like that. You're going to be doing curls, right? Biceps curls, thanks to the radial tubercle. Okay. I think I've talked enough about them. Let's talk about the carpal bones. You do need to know the names of the carpal bones. There's 8 of them. There's 2 rows of 4. They allow our wrists to do amazing things. They allow our wrists to go this way and that way. They also allow our wrists to go medial and lateral and really go wherever we need it to go. That is because all 8 bones can basically slide over the bones that are near it, and each one of them just slides a little bit, but that allows the wrist to have great range of motion. The scaphoid, the lunate, the triquetrum, and the pisiform. That's the ones on the proximal row, the trapezium, trapezoid, capitate, and the hamate. The hamate is about the only one I can remember very well. And the reason I can remember it so well is because it has a thing on it called the hook of the hamate, which you can see right here in this hand bone. So just take a hand like this. I'm not going to give you 8 bones and say what's this one and what's that one. They will be attached like this, or they'll be on a picture of the wrist, and so forth. My clinical point to make on wrist bones is that this bone here, called the trapezium, I believe is the one. A lot of people will fall on their wrist, and they'll have pain in their wrist. Okay, it hurts. And they go into the doctor, and he says, well, we better x-ray that. And they x-ray it, and they don't see a fracture. And they send the patient home. But the most important thing they tell the patient is, if this pain doesn't go away in the next 2 or 3 days, you must come back. And we need to re-x-ray it or even do a CAT scan of your wrist, because fractures of the trapezium are really hard to see. Sometimes they'll show up 2 days later if it's bled in between the fracture line, push the bones apart a little bit. But a lot of times you just have to do a CAT scan. Now, why is this important? Well, here's the deal. If the way the bone, I'm just going to draw it as a square, the way the bone gets its blood supply is from one side. There's blood vessels that go into this bone. And when you break the bone, you usually break it across the middle like that. Well, you can probably see that if you break it across here and it's getting its blood from this side here is going to just die. And when it dies, it's going to just turn into scar tissue, and you're going to have a very bad wrist the rest of your life. Your wrist won't work well because it's got a piece of dead bone sitting in the middle of it. Okay? So that's why it's so important to be sure those patients don't just go home and say, oh, well, yeah, it kept hurting for months and months. In fact, it's never quit, doctor. 5 years later, it's still hurting. Well, you got to treat them appropriately. And so what you do is, if you have a break of the bone, you can get it to heal as long as there's no movement in the wrist. And so people that have that bone fractured will go in a cast for like 5 months, very long time. But if you mobilize the wrist so you can't move it at all, the bone will usually heal, and then you won't have all those problems. So nobody likes to wear a cast, but believe me, it's really worth it with your wrist bones. You don't realize how you need them all. Yes?
This is like a question in general, but like if you just don't treat a broken bone, what happens to it?
Well, number one, it either heals. If it stays close enough if it's still close enough together, line up, and you don't move it and break it and re-break it every day, it'll probably heal. Otherwise, it goes to what's called non-union, and then the bone develops callus around the end of it, and the other end of the bone develops callus around it, and then it'll never heal. And that's probably not what you want. You want every bone to heal back together. And so every bone fracture is going to either be immobilized. Usually, the easy ones you can immobilize with a cast. Assuming it's not way out of line like that, you can put a cast on it, hold it in place, let it heal. Or you got to go do surgery on it and put screws in it or plates or something to hold it together so it can then heal properly. Does that answer your question? Okay, so wait a minute. We didn't talk about the a little bit more. So here's the 8 bones, as I mentioned. Following that, we have these bones right here, which are called the metacarpals. Now, the metacarpals, if you look at them, they're the ones that form your palm, the palm of your hand. This is where the metacarpals are. Look at the back, and these are the metacarpals between here and there. You have 5 of them, as illustrated up there. 1, 2, 3, 4, 5. So the thumb is metacarpal number 1. Probably the most common fracture in the hand is metacarpal number 2. The head of that metacarpal, because guys think it's really macho to go to bars at night and drink and get in fights and punch another guy. And although it looks so cool on the movies, it doesn't really work the way they show it. Because if you punch somebody hard enough, you're going to break your wrist before you're going to break their head. And so it was not unusual every weekend, even in the Dalles, little town, bunch of drunk cowboys would come in with a broken head of their metacarpal. And the problem is it would always break right about there. And because there's muscles attached to the end of the metacarpal, it would bend over. And so the bones, the metacarpal, which should look like kind of about like that, would be broken right across here, and due to the muscles, it would become like this. Like that. The muscles were attached out here, and they would pull this piece down. So every one of these has to go to the operating room. That's the only way to get them lined up. You can try to push it back up and put a cast on it, but it won't hold. It'll fall back off again and go back to this position. So what you do is you sober them up. They get to sit in the ER or up in a bed on the ward till morning, and they get sobered up. And then you tell them, sorry, mister, you gotta go, need to get your finger pinned. And so you go up there and you pull it back up, and then you put a pin right down through the end of it so that the pin goes all the way down into the metacarpal. Usually just leave it sticking out the end, and then it'll heal, and it'll heal in line the way it's supposed to.
Can you take the pin out?
Yeah, you take the pin out usually about 12 weeks or
Is
so.
that more
Just
pain?
pull it out.
It's more pain when you take the pin out than when
Not much. Well, you can't really, you got to do it under anesthesia at the time. But pulling pins out is not a big deal. it hurts for a second.
I had 2 pins that crossed in my middle finger, and yeah, I didn't realize when I went in that he was just pretty much like
Just grab it and pull it
grab a
out.
hole and you pulled it out. Yeah,
Yeah.
I threw up.
It was out before you knew it.
Yeah, and it just felt funny and kind of sickening. Yeah.
Yeah. Well, the point is, don't get in bar fights. Yeah.
And we hear of like boxers fractures.
That's a boxer's fracture. Exactly what I'm talking about. That's the other name for it, a boxer's fracture.
Oh, okay.
It's the
I
head of
thought
the
it
head of.
was the outer.
Well, you can break this one. You can call that can be a boxer's fracture too. You can break all 4 of them. Hit something hard enough. This one I found is the most common one because most people tend to lead with this part of their hand as opposed to leading with the lateral part of their hand. Couple things for you to know here. There's 5. I told you there's 5 metacarpals. Please notice that there's 3 phalanges then attached to the fingers. So here's your little finger. You see it's got 1. We call that one the proximal phalanx. The middle one we call the middle phalanx, and the last one we call the distal phalanx. But now look at your thumb, and you'll realize that your thumb only has 2. It has a proximal phalanx here and a distal phalanx. There is no middle. Yeah.
My son had osteomyelitis in the distal part, and
Mhm.
he had multiple surgeries, and they actually had to remove that whole little.
They just took the distal phalanx off.
So now his thumb is very, I call it bulbous, but it is. It's like this round.
Yeah, it's got no bone in it.
But after it was all healed, he broke it.
Very
So,
good.
Yeah.
Kids will be kids, won't they? All right, so there's 14 total phalanges, right? There's not 15. Only 14 because you only have 2 in your thumb. Okay, now let's go to the pelvis and the lower part of the body. The pelvis is made up of 2 hip bones. And don't get confused too badly by this, but this is a hip bone right here. This bone is called the coxal bone, okay? And you have 2 of them, one on one side, obviously, and one on the other. And, oh, looky here. I actually have 2 of them in this box. Okay, they fit together like that. And then back here between them and back is the sacrum. Remember, but the sacrum is part of the axial skeleton, so we kind of separate it out right here. But these are called the coxal bones, and each of the coxal bones is made up of 3 bones, 3 other bones, which we call, they are named the ilium. Okay, and remember that the ilium is this big one in the back that has these wings on it. It's the wing you feel right here. And then it's got these points out front, which are the points you feel right here in front. And then this area, this is called remember the auricular surface of the sacrum? This is where the sacroiliac joint is, where the sacrum here and the ilium right here go together. Okay, sacroiliac joint. Now, another point, despite the fact that in A and P we divide these between the axial and appendicular skeletons, remember that the pelvis is a solid ring, okay, in real life. So when you break your pelvis, it's like breaking a ring. You don't just break it in one place, you have to break it in 2 places. Make sense? And usually one place is a fracture, and the other place is oftentimes just a dislocation of this SI joint. The SI joint may be sprung or pulled apart, or the other major cartilaginous joint, which is out in front, where the 2 pubic bones come together in front, called the pubic symphysis, right down there. Got it? So a pelvic fracture is a bad deal for a number of reasons, mainly because people bleed to death from them because there's lots of big blood vessels live right around the pelvis. But we'll get to that later. So these 2 coxal bones, and that's a coxal bone, They're made up of 3 bones: the ilium, which is this part up here, the ischium, which is this part down here. This is the ischium. This is what you sit on. You sit on your ischium bones. And then the pubis, which is this front part up in here, where the 2 fuse together. Okay? So this bone is made up of 3 bones. I'll show you better pictures because you don't really see the lines very well with them. So here we go. They've got them color-coded up here. The ilium is by far the biggest. The pubis is the one across the top here and extends down a little bit. And then the ischium is the one back here. That's the one you sit on. So that's the one you feel up in there. As illustrated right there. Now remember, that pelvis is also the rate limiting factor in most ladies having babies. And so we'll talk about how that works here in a minute. So overall, your pelvis, the whole ring, really consists of 1 sacrum, 2, 3, 4, 5, 6, 7 bones, doesn't it? Notice that the sacrum sits right below this bone here, which is called L5, right? The 5th lumbar vertebrae. The ossicocci are kind of cool. Once again, you just need to get one in your hand and play with it a little bit. This is the sacroiliac joint back here, which is this really rough-looking area right here. This is the pubis up here, which is illustrated right there, and it has a bunch of fibrocartilage in it. Remember fibrocartilage that can give way and relax during childbirth? Your pubis can actually open up several centimeters. When you're having a baby, it'll actually open up like that to make more room to get that big head out. The joint out here is called the acetabulum. This is the acetabulum right here. It's the hip joint where the femur is going to fit into there. This is called the pubic tubercle right here. This hole here is called the obturator foramen. Some big blood vessels are going to go in, nerves are going to go out through the obturator foramen and go down your leg. This is an important spine right here. This is called the ischial spine. Ischium is that bone down here that you're going to sit on. This little spine here, though, is really the overall rate limiting factor to whether your baby's going to come out or not. Because the distance between the ischiums is really key in getting the baby out. Okay? We'll talk about male versus female pelvises before we're done here, because they are different. Looking at the back side, you need to know there's an iliac crest up here. That's what you hang your belt on, more or less. You've got posterior superior, and posterior inferior iliac spine back on the back, and then up front you have a anterior superior and anterior inferior iliac spine. 4 spines on the ilium. This big notch under here, right here, is called the greater sciatic notch. That's where your sciatic nerve comes down to go to your feet, which you see illustrated right here. Okay, the acetabulum is called the hip socket, and it's on the lateral side of the coxal bone, and of course your femur is going to fit into it. Femur is another ball and socket joint, much stronger than the shoulder joint because it's a lot deeper. It really holds it in. It's very hard to pop your hip out of joint. Occasionally people dislocate a hip, but it's a rarity, and it usually takes a hell of a trauma to make that happen. You're talking a 60-mile-an-hour car accident to dislocate your hip, or some football crash that idiot football players run into each other, really fast. Notice that the acetabulum, the hip socket, is actually made up of all 3 bones, because the acetabulum is where the 3 bones, the pubis, the ischium, and the ilium all come together. So all three of them contribute to the acetabulum. I'll show you a pretty picture in a minute of that. Acetabular notch is this little notch right here. It's not a completely perfect socket around there. There's a hole in it right here called the acetabular notch.
Can you can you show me again the notch?
Right here. Yeah. They've got it on this picture right here, acetabular notch. Well, here's a good example of what I was just saying, that all three of the bones contribute to the acetabulum here. You notice that the purple contributes part of it, and the ischium, the yellow, contributes part of the acetabulum, and the pink, the pubis, makes up part of it. So the socket itself is made from all three bones. As far as marks on the ilium, I've already kind of mentioned them. The greater sciatic notch is this one here. The iliac crest is this upper brim here. The iliac fossa is this fossa right in here, kind of on the inside. Ischial spine is this one here that I mentioned. The ischial tuberosity is this thing here that you sit on. Ischial tuberosity. Ischial ramus is this is the inferior ramus of the ischium, and here's the superior ramus. The inferior comes over here to meet the pubis, as it says there, and the ischium comes back this way. Pubic symphysis is where the two pubic bones meet. Obturator foramen is the big hole I've already pointed out to you. Pectineal line is a ridge along the superior ramus of the pubis, and that is located right here, right at the top of the pubis. That's where your abdominal muscles insert in there. So when you're working on your sit-ups and you're doing your crunches, it's pulling on muscles that are attached to this little line right here, across the top of your pubis. It's giving you your six-pack. Right. Okay, I think I don't need to go through that because I've done it. Sacroiliac joint, I mentioned, it's the one in back, the big ugly one here. It's very irregular. You'd think you could never pull that thing apart, but believe me, when people get in car accidents and break their pelvis, they oftentimes spring or pull apart their sacroiliac joint. The pelvis, I don't really want to talk about it because I can't pull them all together really, but the pelvis consists of the two coxal bones, the sacrum, and the coccyx. The coccyx hangs off the back end of the sacrum, remember? Down here at the bottom, the coccyx. Let's talk about the divisions of the pelvis, and this is where it would be nice if I'd brought a complete pelvis, but I didn't. The pelvic brim is where the top edge of the true pelvis comes, and then there's the bottom part. Let's go ahead and look at this picture right here. So this is the false pelvis. This is the whole thing. It really doesn't count. The part of the pelvis that really counts and is really important, especially in childbirth, is the true pelvis, which is below this line here called the pelvic brim. And this is the pelvic brim right here. This is not. This is the false pelvis up there. This is the pelvic brim. This is looking down from the top. So here's the sacrum. There's the coccyx. Remember, L5 is going to sit right on top of the sacrum there. Looking at it from the side, the false pelvis you see is above the line there. Down here is the true pelvis. And remember from day one of 231 when we talked about the abdominopelvic cavity and I said there's really no separation between the two. Well, that's true, there is no separation. It's just kind of a magical line. And this is really where the line goes. It goes from the sacral promontory to the top of the pubis. So it kind of goes from, if we can put this baby on here for a second, it kind of goes from this point up here, the sacral promontory, to the top of the pubis, up there in front. Does that make sense? Picture's better. This is the real critical distance, because this is the shortest in most women, the distance between the ischial spines. Now, you know that in this country there's a lot of talk about how there's too many C-sections done, and that may be true, but let me tell you, there used to be hundreds of thousands, and indeed millions of babies and mothers who died when the baby couldn't come out. Until we started being able to do surgery, which really wasn't until the 1910s. Okay, 105 years ago was the first time that in this country, and we're as advanced as any place, that we were actually able to take ladies to a hospital, put them to sleep, make an incision on their tummy, and get the baby out, and have both the baby and the mama live. Okay, so it was a huge step forward, but it's like everything. It's got its controversies too. Comparing the male and female pelvis, we have male pelvises and we have female pelvises over there in the lab. You need to take them both in your hands and look at them and see the difference. The female pelvis is smaller. I mean, it's lighter. It's not as strong because men usually are bigger people. They have more muscle and weight to them. As a result, the muscle and ligament attachments, these little lines and tubercles where muscles attach, aren't quite as big in women as they are in men because the muscles aren't as big in women as they are in men. The modifications that have been made for childbearing is an enlarged pelvic outlet. There's a wider the pubic angle. I'll show you that in a minute on another slide. Otherwise, it doesn't make any sense, I don't think. There's less curvature to the sacrum, so it makes for more room down there. Women generally have a broad, low pelvis. That gives them hips. You know, guys, skinny guys don't have any hips at all. They just kind of go down. The ilia, these wings in men kind of go up, and in women they kind of lay out. So once again, I'll show you, here's the comparison slide, which is really quite, I think, quite helpful. So this is the male on this side, this is the female on this side. Notice that this big opening here is a good bit bigger in the female than it is in the male. These ilium here are more in men, and they're more out in women. The sacrum hooks more in men and stays back in women, once again to make a bigger outlet there. This is the deal that the book talks a lot about, and it's really obvious when you have a male and female pelvis sitting side by side, and that is this angle down here. The angle between the two pubic bones here, ischial bones, I guess, is 90 degrees or less. Usually it's a lot less in males, and in females it's much wider, greater than 100 degrees in females. So that's kind of something you probably ought to know, is the variations between the male and the female pelvis. This is just a picture of the male. Once again, the ischial spines are really close together across the middle, and this angle is very sharp, whereas in women, it's a lot more room across between the two ischial spines, and it is much more flared out here, once again, to make more room. Lower limbs, let's talk about them for a minute. Obviously, there's the thigh, or the femoral area, and the leg and feet. The idea of the lower limbs is basically to bear your weight and to allow you to move, allow you to walk. Leg means lower leg, thigh means upper leg. I think I've made that point several times now. So what are the bones of the lower extremity? Well, the one bone in your thigh is the thigh bone, also called the femur. Okay, the femoral area. Remember, we're going to have femoral arteries, we're going to have femoral nerves, we're going to have femoral muscles, all kinds of femoral stuff, because that's the thigh. And the patella is the kneecap. Remember, the patella is a what type of bone? Sesamoid bone. Is the only one in our body. The tibia and the fibula are the two leg bones. So just like we have two bones up here in our arm, we have two legs in our forearm. We have two arms, two bones down there in our leg, called the tibia and fibula. We have a series of tarsal bones. The tarsal bones are equivalent to the carpal bones up here in the wrist. They don't look anything like the carpal bones, let me tell you. And you will need to know them because you need to know how they kind of interact together. Metacarpals or metatarsals, yeah, that's all right, are the foot bones, and then the phalanges are the toes. Once again, we have metacarpals, metatarsals we call them down here, and then we have phalanges. And once again, we have 14 phalanges in the lower extremity. Why? Because our big toe only has 2, right? You can play with that tonight. See if you can figure that one out. All right, let's start at the top here. Look at the femur. The femur has a head to it. It attaches kind of at the fovea capitis. The fovea capitis is this little socket here, a little hole right here that's in the head of the femur. The neck. This is the femoral neck, and that's where most people break their hip, is they break the femoral neck. It's the narrow area between the head and the trochanters. These are the two big trochanters. Remember, what did we call them up in the arm? Femurs. The two big bulges, we call them greater and lesser tuberosity. Keep them straight. But the femur basically has 2 trochanters, they're really big and bulgy looking. That's because these are where the thigh muscles, the muscles attach that make our legs do things like this, up and back. Very big muscles, biggest muscles in your body. As a result, they have created the biggest bulges on bones in the body. This is the shaft. Proximal epiphyses involves these 2 trochanters, the greater one and the lesser one. The intertrochanteric line is this line right here that runs between the 2 trochanters. It's the intertrochanteric line from one trochanter to the other. The linea aspera is a prominent ridge down the shaft. This is it right here. Runs down the back side of the femur. The distal epiphysis has 2 condyles, 2 epicondyles, same as we had in the arm. Medial epicondyle and lateral epicondyle. So if you put your foot up there and you feel the big bulges right here on either side, that's what we're talking about. The medial and lateral epicondyles above the knee joint. This is the medial condyle here, the smooth part, and the lateral condyle is there, and between those is the intercondylar fossa. That's the fossa in between the 2 condyles. Okay. I'd probably just as soon get rid of that thing up there. Telling me I don't have any more disk space. Thank you very much, Steve Jobs. Okay, so here's pictures of them. I've kind of illustrated all these things to you already. I think it's really important. You need to be able to tell right from left, obviously. And the way you do that is just remember that this is the front side of the knee out here. This is the back of the knee back there. They look very different. And obviously the femur is always going to, the head is always going to come in from lateral because remember the acetabulum, the socket here, is on the lateral side of the pelvis that it fits into. There's one more little deal here called the adductor tubercle. That's right here. This is the adductor tubercle. Remember what adduction? What's adduction? No. No. Adduction is bringing things into the middle, adding to the middle. Remember? Adduction. You got to get those straight because there's going to be a whole lot of muscles that are going to be called adductors, and a bunch of muscles are going to be called abductors, and so forth. And so this is the adductor tubercle, and as you can see, it's on the medial side, so it's attached to a bunch of muscles that go up here basically to your pelvis and cause your thighs to pull medially, to adduct your thighs, to bring them together. Okay? There's a little tubercle down there where a bunch of adductor muscles will be attached to. Remember the area behind the knee is called the popliteal area. Remember that one? We come back to all this stuff. The patella, also called the kneecap. I do not expect you to be able to tell the difference between a right and a left patella, but I think you should be able to tell the difference between the front of the patella. Remember, this is actually found in the tendon, and the back side of the patella, which actually is nice and smooth and forms part of the joint. Okay, the joint down here includes the patella from the back side. So the patella actually it fits right here. See, into the front side of the femur. Got it? So the patella is part of the knee joint. Which is kind of weird. Something to think about. It has corners. I don't think these are important. Just know that there's a front and back side. It's in the tendon of the quadriceps femoris. It's called the quad or the quadriceps femoris. It's this big muscle on the front part of your thigh here. It's called that because it has 4 heads to it, 4 parts. We'll learn those when we get to muscles. But basically it's the muscle that allows us to do this. When it contracts, it makes our knee go out. Okay? Enough about the patella. Just notice that it's nice and smooth on the back side, and you'll be in pretty good shape. The tibia is called the shin bone. Looks like this. You have 2 bones in the lower extremity down here, and one is called the tibia, and the other one is called the fibula. Now, it's not called the fibia, it's called the fibula, okay? This is not called the tibula, it's called the tibia, okay? Now, let me just say the shin bone is really a difficult problem in a lot of folks. We would have people come in that had torn up the front of their leg down there on hit a rock or something, and the skin over your shin is incredibly thin, and it's incredibly difficult to heal. So it's not unusual to have somebody, if they ripped their leg down there and had an incision maybe that long down their shin, that thing might take 6 months to heal. Even a healthy young person. And if it's an older person or a diabetic, it might take a year. As an example, sew up somebody's face, you'd usually have them come back in 3 days to get their stitches out. Somebody cut on the chest, you'd probably have them come back in 7 days. On the lower extremities, from the thigh down, you'd probably leave the stitches in for 14 days. Things just heal slower down there. But on the shin, you might leave them in a month because the shin is the poorest healing area Football players, occasionally you'll see they'll break their tibia and they're out for the season. Why? Because our tibia carries all of our weight. 100% of our weight is carried by the tibia. The fibula, which lays alongside of it over here, all it does is serve as a focus, as a place for muscles to attach. So, LaMichael James, I think one of the running backs from Oregon, broke his fibula a few years ago. I think he missed 2 games. He was back out there because it doesn't carry weight. It hurts like hell, but I don't know. Maybe they numbed it up or something. Anyway, you can't really hurt yourself with a broken fibula. So the tibia has got medial and lateral tibial condyles. These are the condyles right here, the smooth parts, where the femur is going to fit on top of that, right? The medial and lateral condyles of the femur are going to fit on the medial and lateral condyles of the tibia, and that makes most of your knee joint. The tibial tuberosity is this thing right here on the front of your knee. So if you take and here's your kneecap right here, and this big bulge right there below your kneecap is the tibial tuberosity, which is basically this big thing right here, and that's what those quads attach to. So the quad muscles come down here, the tendon separates and surrounds the patella, goes across the knee, and inserts right there into the tibial tuberosity. Make sense? The shaft of the tibia has got this anterior margin, which is the sharp ridge that you feel at your shin. The distal epiphyses, the tibia forms the medial malleolus. The medial malleolus is this part right here. Right here. The bulge on the medial part of your ankle is made up of the tibia, and it's the medial projection at the ankle. The fibula is mostly just muscles attached to it. Like I said, it's much smaller. It lays out here lateral to the tibia and much smaller than it, like I said. The tibia and the fibula articulate both up here at the top. There's a little smooth area right up in here where that thing attaches to, and then down here distally, it fits in that little groove right there and forms part of the ankle down there. I think it goes this way, actually. This is the hardest one for me to keep straight. I would tell you the way to learn it is be sure you go look at the skeletons that are in lab, because they're all wired together and they're wired right. And the problem that we face with these boxes of bones is that, we'd like to think they're all perfect set, but sometimes they're not. And I don't know whether this is a right or a left fibula. It looks like it's about the right length for this one, but anyway. So keep that in mind. We won't trick you. Interosseous membrane, there's a membrane that goes between the tibia and the fibula all the way down. It keeps these two from separating. They always stay about the same distance apart, even if you twist your ankle. Here they are. Please notice that down here at the bottom, the ankle joint, let's call this the talus, which is the bone that attaches right there. See, it fits right up in that little 3-sided box. And the lateral malleolus is made up of the fibula. On the lateral side, it's fibula. Then there's the flat part called the inferior articular surface, which is part of the tibia. And then there's the medial surface over here. You kind of got to line all 3 of these up to put it back together to make the ankle work. And so most ankle fractures, because they usually involve breaking this thing off here, and they usually involve breaking the neck of the fibula, and everything's kind of out of wonkus there. They kind of all have to, most all ankle fractures will go to the operating room and get put back together with little screws and pins to make sure that that is all lined up just right. Otherwise, the patient will have a non-functional ankle the rest of their life. I think I'm done talking about that. The ankle has 7 tarsal bones. Here's the ones you need to know them all. But let me tell you the main points to know. I believe The talus is the one that the tibia sits on. And the talus is the one that carries all the weight. Remember, the tibia carried all the weight down there, and then it goes into the talus, and this is the talus right here. So the tibia, once again, I may be, it's medial, yeah, that should be right. So it fits right there on top of that bone. So it fits on the talus. Now notice that the talus is not your heel bone. You might think that you carry all your weight on your heel bone, but you don't. The heel bone is called the calcaneus. Calcaneus, that's your heel bone. And the calcaneus is where the big muscles on the back of your calf are attached, right here, and they make you point your toes, right? And we call that tendon Achilles tendon, yeah. Because remember when Achilles' mother took him and dipped him in the, it's an old story, dipped him in the river Styx to protect him. That's the only part that she didn't get in the water, and that's where he got killed by an arrow in the Achilles tendon. That was his weak spot, his only weak spot. Sad story. Okay. Now where did I put my clicker down? Somewhere. Here it is. Okay, so that's the two biggie back ones are the talus and the calcaneus. The cuboid is the next one. It articulates with the calcaneus up here. Then there's the navicular and the three cuneiforms. These are the three cuneiforms. They're kind of wedge shaped. I think that's what cuneiform means. And medial, intermediate, and lateral. And I'll just leave it at that. Once again, you've got 5 metatarsals, not metacarpals. And, and you've got 14 phalanges, distal to that. I would just tell you from a functional point of view, we really don't need our toes. The only one we really need is our big toe, because when we walk, we push off virtually completely off of our big toe. So we used to kind of think about that in surgery. If people had these toes out here that were dying, you just kind of had to take them off because they probably weren't going to heal. But you wanted to do everything you could to save somebody's big toe because that's what they were going to walk with. Metatarsals, phalanges. Hallux, remember, is the big toe. Pollex is the thumb. Remember that? I think I've said all I need to say there. Let's talk about the arches of the feet just a bit. You've heard of people having flat feet or fallen arches. There's a longitudinal arch, which is the arch that goes front to back. So that's this arch right here. It goes this way, and it has 2 main parts, the calcaneal portion and the talar portion on the medial side over here. The transverse arch is the arch that goes this way. That allows us to kind of go back and forth between the 2 sides of our feet. There you go. There's the transverse arch going that way, the longitudinal going this way. When we stand, here's a point to know. When we stand, we put about half of our weight on our calcaneus as far as the weight going to the ground. Remember I told you all the weight comes down through the tibia, all the weight goes into the talus right here, but from the talus it sort of splits, and about half of it goes into the calcaneus, and about half of it goes up here into what we would call the head of the metatarsals, also called the ball of the foot, right? So we put about half of our weight back here and about half of it on the heads of the metatarsals up here, and that's why when you stand, you can kind of rock back and forth to keep your balance. The last thing is that the skeleton reveals all kinds of clues about us. You can get a hold of one bone, let's just say this bone here, and you can probably figure out the sex, the age, If you have an arm bone, you can tell the handedness. In other words, whether someone was right-handed or left-handed, especially if you have both of them so you can compare them. Because my right arm, I can promise you, is bigger than my left arm because I'm right-handed. And I've played tennis with my right arm, and you do a lot of things with your dominant hand that you don't do with your left. So in general, you can tell handedness. You can tell sex not only by the shape of the pelvis, but also just by the overall size of the bones. And that is it. Okay? So we'll go to lab in a little bit, and we'll take a little quiz, and we'll have some fun.
I'm sorry, it didn't.
No problem. Made it for the quiz.
Yes.
Oh, you did, and you did make it this morning, you mean? Yeah, no problem.
I feel better, a lot better about this chapter than the last chapter. I feel like there's just so much in the last one.
Okay, good. Yeah, this is not hard stuff.
No. Going to open lab helps, you know?
Oh, it really does.
Alright, thanks.
Yep.